urethra that runs through the prostate and through this sphincter mechanism here that protects from leakage, and then out the urethra. When a man doesn't want to urinate, there's protection in muscle that's in the prostate and in the sphincter, which is a circular muscle that's contracted at all times, except for when you're voiding, to keep the urine in place. We'll get to this in a second, I think. So what types of incontinence are there? Incontinence meaning the loss of urine. So one type of incontinence is urge incontinence. So the bladder squeezes so much or too often, and it pushes the urine out through this tube too quickly. But the part of incontinence that I want to focus on today is called stress incontinence. Most commonly when there's an injury to the prostate, which is part of the protection from leakage, and the man is relying only on this external sphincter, and that sphincter isn't strong enough to keep the urine in place. And then when a man coughs, sneezes, lifts something heavy, does a quick motion, there's pressure from inside the belly on the bladder. The bladder then is pushed, and then the urine then pushes beyond this muscle mechanism, and the urine then drips through. There's also the possibility that a man having mixed incontinence, a combination of both of these type of leakage. So who gets stress incontinence? So stress incontinence really is related to prostate surgery, where there's injury to the muscle inside the prostate that protects from leakage, and therefore you're relying only on that external sphincter musculature. Most commonly it's from prostate surgery for prostate cancer, but also sometimes when men have prostate surgery for benign reasons for enlargement of their prostate. Additionally, men that have radiation therapy, pelvic trauma, or neurologic diseases can have stress incontinence. Stress incontinence can affect a man's quality of life for many reasons. And looking at how this happens, as I mentioned before, almost 200,000 men a year are diagnosed with prostate cancer, with about 70,000 men having a radical prostatectomy or removal of the prostate. When the prostate's removed, there's an incision right here at the bladder neck, right where the urethra begins, and at the bottom side of the prostate, and the prostate is then removed. These nerves run adjacent to the prostate, and those muscles that are inside the prostate are removed. And then everything's sewn back together. After a radical prostatectomy, a high percentage, about 9 to 16% of men, will have leakage of urine initially. And as men heal after their prostate's removed, their body accommodates and adjusts to this, and the muscles that are left behind are able to strengthen, often with Kegel exercises, in order to strengthen those muscles and reduce how much leakage they have. So what are the options for treatment for men that have stress incontinence after prostate cancer surgery? Well, in the short term, like I mentioned, a very high percentage of men will have initial leakage, and then they will drop down to about this remaining 10% after about a year. So to start with, I usually recommend that a man reduces how much fluid they have in their bladder before they go out, before they lift something heavy, before they go out and decide to play sports, or before they have sexual activity, in order to reduce how much urine there is in the bladder to leak. So plan bathroom breaks, emptying your bladder before you do activities. In order to strengthen those muscles that are left behind to prevent leakage, often men will do pelvic floor physical therapy exercises, either on their own as instructed by their doctor or their physical therapist, or together with a pelvic floor physical therapist that can really help a man focus and strengthen those muscles. Finally, pads, diapers, and external catheters can help cope with leakage. I always remind myself and remind patients that not intervening and not trying to fix incontinence does have a cost, not only a quality of life cost, but also the cost of protective pads and things like that. But as you get to a year after your prostate's removed, if you do have persistent or bothersome leakage, there are 2 surgical options that we have for men that are looking for long-term treatment. One's a male sling. A male sling is a surgical procedure where we adjust that remaining muscle and give it a hammock underneath it in order to give it extra support. That extra support allows more pressure to be delivered without leakage. This is placed through the hip bones and adjust the urethra so that when a man coughs, sneezes, or lifts something heavy, they don't have leakage anymore. This is a surgery that's really best for men with what we consider mild to moderate urinary leakage. Another option is something called an artificial urinary sphincter. This is a cuff that's placed around the urethra and holds pressure at all times. So then when a man has that heavy lifting or coughing, there's a closed circle stopping the urinary flow, and that will stop a man from leaking until that man desires to pee by activating a pump that's in their scrotum. I have some pictures here to explain these both a little bit more. So the male sling, as seen here in this picture here, is this piece of mesh that's looped through the hip bones. And if you look at cross section, it looks like this. This piece of mesh is placed right under the urethra, and this is that muscle unit right here underneath this blue line right at the bladder neck. When that mesh is tightened in this last picture on the right, it widens the length of support, and therefore the man's natural muscle is able to do a better job protecting from leakage from coughing and sneezes. 90% of men or more would recommend a procedure like this, and over 90% of men are satisfied when they have the surgery. Again, a man has to have their natural muscle left behind. So this is usually men that leaks 1 to 3 pads per day. And when they come to the office, I do a cystoscopy or a look inside their bladder to see how much muscle they have behind. We can decide if there's enough muscle to be supported. It's an outpatient procedure, and this men can either go home the same day with a catheter in their bladder, or oftentimes I'll keep men overnight and we'll remove their catheter the next day. Right after the procedure, this device does work on its own. After the procedure, you really do need to take it easy, about 6 weeks. The mesh is in place, looped through the hip bones, and therefore it needs to heal into place. So I recommend that men really take it easy for about 6 weeks to allow that to maximally heal in the best way possible. The other option, the artificial urinary sphincter, is a little bit more of a complex device. This device is placed with a small incision under the scrotum where we find the urethra, the tube to urinate through, and place this cuff. I really think this is ideal for men that have heavy leakage, so more than 4 or 5 pads per day, men that either have had a sling and it hasn't worked for them, or men that have had their prostate removed and radiation therapy and persistent leakage. Men that have had radiation therapy as well as their prostate removed sometimes don't do as well with a sling, and I tend to recommend this procedure. We put this cuff here around the urethra after we find the urethra itself and protect it, and then connect these other mechanisms. This control pump that sits in the scrotum connected to what's called a pressure regulating balloon. Once the device is activated, which is about 6 weeks after surgery, the device is turned on, and this pressure balloon puts pressure on the urethra at all times. Therefore, no matter what you're doing, you won't leak. If you're sitting around or if you're coughing or playing tennis, there shouldn't be leakage until you press this control pump and turn on the device. So you press this device when you want to go urinate, it opens the channel up, allows the urine to flow, and the bladder can then be emptied and then resets until next time you want to go pee. Sorry, here's a video that should work. Here you go. So the pressure regulating balloon is here. You press the button, then the cuff then opens, the urine can then come out, the bladder then drains, and as you see here in the picture, after about 2 to 3 minutes, the fluid then returns into that cuff, closing it up and causing constant pressure on the urethra, preventing future leakage. Artificial urinary sphincter is a very high satisfaction procedure. Over 90% of patients would recommend it to a friend or have the procedure done again. it really is a very nice option for men with a weakened sphincter. So when they're not able to control at all, meaning that they have more than 4 to 5 pads per day, or men that have failed other types of incontinence procedures, the whole device is placed inside the body. It's really undetectable to others and has a high satisfaction rate. Like any procedure, there is risk. A male sling does have potential problems where it either does not cause enough protection, so you still have some leakage. The sling can be made too tight, and therefore a man may have urinary retention, have difficulty urinating. You may have pelvic pain or discomfort or irritation from the mesh after the procedure. An artificial sphincter also does have potential risk. The device is placed inside the body. There is a risk of infection of the device. It may malfunction. It may cause an erosion or too much pressure on the urethra. It is a complex device, and so the average device does need to have some type of mechanical rewiring or replacement around 10 years or so. And it's possible that a man, we either put the cuff too tight and they do leave urine behind, or we put the cuff on too loose and there's still leakage of urine. That said, overall, there is a high satisfaction rate with both of these procedures, especially for the right patient with the right objectives. Insurance often does cover these procedures. There's no guarantee, but from my office perspective, if you're interested in doing one of these surgeries, we do lots of crossing of T's and dotting of I's and making sure that you do have coverage, or if you don't have coverage, you know exactly what your out-of-pocket expenses would be for the procedure. Fixincontinence.com will have lots more information, and please feel free to look at this website or the Boston Scientific website for other information if you're interested in one of these procedures. I think it definitely important to start this conversation with your current urologist, especially if you had prostate cancer and you're being treated by a urologist. Start the conversation with them, especially if you're one of the patients at my group. I think it's one of those things where if you start the conversation, your doctor that did the prostatectomy or is in charge of your radiation may say, oh, maybe you should reassess this at this time point, or talk about this or make a plan differently than I'm presenting based on your condition. And I work together with lots of my partners here about making sure we have the right timing for incontinence procedures. A prosthetic urologist, someone like me that's interested in these procedures, does tend to have the highest and best outcomes. And so if you're going to proceed with a surgical procedure, please make sure that someone that's comfortable with presenting you with a sling and an artificial sphincter and all the options for incontinence. So in summary, lots of options for men that have stress incontinence, which is a very common 1 in 10 men that had their prostate removed may have some leakage from the side effect of that cancer treatment. And it's important to know that leakage is common in the short term, but as time goes on, there are permanent fixes that we can do with a male sling or an artificial sphincter that can help you long term. So that is the part of the conversation about urinary leakage and stress incontinence. I'd like to open up to questions. If I know we had some technical difficulties, if that's possible. Mike, are you there?
Yep. So right now there are no questions related to incontinence.
I can't hear you.
Can you hear me now?
There we go. I can hear you now.
Okay, so there's no questions right now that specifically relate to incontinence.
Okay.
We'll open it up for people. Remember, use the chat function on your screen to type in a question, submit it for Dr. Goldenberg. Maybe what we can do is move on to the ED portion of the presentation. And if people have questions related to incontinence, ask them and we can touch on them at the conclusion of the webinar.
Okay, so I will then forge ahead on discussing erectile dysfunction. So what is erectile dysfunction? Who has it and what causes it? So erectile dysfunction, or ED, is the persistent inability for a man to achieve or maintain an erection that's firm enough for sexual activity. It's really common. And this always gets me, that, how common it is. And even someone who practices in men's health, I always remind myself that how common this is. 1 in 5 American men over the age of 20, but half of men, or more than half of men over the age of 40 will have some degree of erectile dysfunction. So really very common. That's why I think more and more as time has progressed, men and physicians are really becoming much more comfortable discussing erectile dysfunction with their patients. Over approximately 40 million American men will have erectile dysfunction. So when I think about the erectile process, I usually think that it starts, with in a man's head, they have to be stimulated. They have the right amount of testosterone, which is the hormone that helps men have that libido or sexual urges. Once that urge then goes from their brain to get down to the penis, you have to have healthy blood vessels that can send blood from your heart down to the penis, and normal nerves that are able to then send that signal from the brain down to the penis. In the penis itself, the penis is made of, made of 3 tubes. There's the 2 erectile bodies, as you see here in pink in the flaccid state, and underneath in the middle is the urethra, the tube a man urinates through. When a man gets an erection, what happens is the artery, which is what allows blood to flow into the penis, dilates or stretches, and then blood then fills these erectile bodies. It's only shown as 1 here, but there's 2 erectile bodies, 1 for each side. They fill with blood, and then the blood stays in the penis, allowing for a firm erection. When a man has erectile dysfunction, or the inability to get said process, as we discussed, it can definitely have a significant impact on their quality of life. There's lots of reasons why men can have erectile dysfunction. Most commonly is vascular disease. As I mentioned, this is a process that involves blood flowing into the penis and allowing an erection to occur. If you have any type of vascular disease process where blood doesn't flow as easily as it once did, that can be a really common reason why you do have erectile dysfunction. Additionally, diabetes. Diabetes is a disease process that can affect blood vessels, can also affect nerves, and therefore there's kind of a 2-hit phenomenon to causing erectile dysfunction. Different medications can affect erections, and also prostate cancer treatment and pelvic trauma are also common reasons for ED. So I want to focus on some of these specific disease states quickly to discuss the process of how different diseases can affect erectile function. So diabetes is a really common issue for men in the United States. And men with erectile dysfunction men with diabetes have erectile dysfunction often earlier than non-diabetic men, often 10 to 15 years earlier. And men with diabetes have a less responsive erectile dysfunction than men without diabetes because of the injury to the nerves and to the blood vessels. When diabetic men have erectile dysfunction, often pills don't work as well as they would or could in other men. Diabetes is often the first thing that erectile dysfunction is often the first thing that diabetic men present with, usually a couple times a year. A man comes in and says they have erectile dysfunction, and then I do some blood testing for them, and then we discover that they are diabetic. This reiterates what I talked about earlier, that diabetes not only affects all these blood vessels that go through a man's body, but also their nerve endings. There's this disease process of diabetic neuropathy, and that can affect the way that the nerve signaling goes to the penis as well as to your fingertips and your toes. What's a way for a diabetic man to reduce their risk of having erectile dysfunction as a side effect? Things like good blood sugar control, making sure that you take good care of your heart disease, and different medications, or changing which medications you take to treat your diabetes can affect how you do with your diabetes and erectile dysfunction. So erectile dysfunction and heart disease, as I mentioned, getting an erection is really a plumbing issue. It's getting blood to flow into the penis in order to allow it to fill. The kind of main flow into the penis is the penile artery. Like I said, there's a small artery on each of the erectile bodies that allows the blood to fill in to allow for an erection to kick in. This penile artery is very small. It's 1 to 2 millimeters in size. You compare that to other blood vessels like the coronary artery, the blood vessel that allows blood to go to the heart, or the carotid artery, the artery in the neck that brings blood to the head. Any man that's had arthrosclerosis or narrowing of their blood vessels that cause them to either get a heart attack or have a stroke, they have blood vessels that are 2 or 3 or 4 times bigger than their penile artery that are affected by by poor flow of blood through those blood vessels. And therefore, it's very common for men with heart disease to have erectile dysfunction, and vice versa for men with erectile dysfunction to be at higher risk for heart disease. And that's reiterated here, that oftentimes symptoms of heart disease will develop in men 2 to 3 years later than they have erectile dysfunction and are at higher risk for having a heart attack. How do you reduce your risk of erectile dysfunction with men with their heart health? Diet, exercise, losing weight, quitting smoking, and reducing stress are all factors that can help your heart disease and therefore help your erectile dysfunction due to blood flow. So low testosterone, as I mentioned, testosterone is the hormone that's produced from the testicles that gives a man libido or a sex drive. As men age, often they don't produce testosterone as well as they once did. And approximately 40% of men over the age of 45 have a drop of their testosterone. Often this coincides with other really common issues that can cause erectile dysfunction, like being overweight, having diabetes, having high cholesterol, high blood pressure. So often men present with a low testosterone and erectile dysfunction for either that reason or other reasons as well. And I think it's an important thing to get your testosterone checked, which is a blood test that can be done at pretty much any office. Oftentimes, I see patients that have already seen their primary care doctor or a different urologist and have their testosterone checked, so they've already been evaluated for that or been started on testosterone medicine. Oftentimes, starting a man on testosterone medication may help them with erectile function. Additionally, testosterone is important for other parts of a life. Important for having sex drive and libido, but also helping with concentration, muscle strength, helping with weight loss, and overall helping with a feeling of more motivation and better concentration. So if a man is diagnosed with low testosterone, which in my mind means they need to have 2 blood tests in the morning time. So testosterone peaks in the morning and does drop in all men as the day progresses. So I recommend that you should have a blood test for your testosterone before 10 a.m. on 2 occasions. If you have low testosterone on both occasions, it's worthwhile to consider that having a low testosterone is part of the problem with erectile dysfunction. There's lots of medications that can be given for raising the testosterone, and in the last couple of years, there's really been an increase on the availability of different types of medicines to help with testosterone. And those include gels that go on the skin every day, injections that are usually given weekly, pellets that are placed under the skin every 3 to 6 months. There's a new oral or a pill form of testosterone that can be taken twice a day. In addition, testosterone can affect fertility issues, and therefore, if you're thinking of conceiving in the future, there are some off-label medicines that can be given for a man with low testosterone that wants to have future children. So erectile dysfunction and prostate cancer treatment. The slide should look familiar. It's similar to the one that we looked at before when we talked about urinary leakage. The prostate, again, sits right here, right at the base of where the bladder and the urethra is. These nerves that run next to the prostate, which I talked about during a prostatectomy, are removed or peeled off the prostate, are the nerves that are important for helping a man get an erection. So when those nerves are then pulled off the prostate in order for its removal, it does injure or temporarily paralyze those nerves. So after the surgery, these nerves that are important for getting erection are injured to some degree, and they take time to come back. The literature would say that about 50% of men that have prostate surgery do have worsening of their erectile function than they did before their prostate cancer treatment, either if their prostate cancer treatment was with surgery or if it was with radiation therapy. Men that had both radiation and surgery for removal of their prostate and treatment of their prostate cancer are at even higher risk of having erectile dysfunction subsequently. Peyronie's disease. So Peyronie's disease is something that people are hearing about more and more because for the first time in the last 5 years, we have a medication that can help with Peyronie's disease. But Peyronie's disease is when a plaque or forms in that erectile body. So like you saw here, this is just a different diagram showing this white is the erectile body, and underneath the urethra that's urinated through. When some injury occurs in the erectile body, usually bending of the penis during sexual activity, an abnormal scar can sometimes occur, really happening more commonly in men in their 50s, 60s, and 70s. This plaque therefore becomes less stretchy than the rest of the penis. And when a man goes to get an erection after this plaque has occurred, they develop penile curvature. If that curvature is bothersome enough to make sexual activity more difficult, there are options. Like I mentioned, Xiaflex is the only FDA-approved treatment for Peyronie's disease. This is an injection into the plaque to help break that plaque down. In addition, surgical treatments can be performed, either application procedure where we shorten at the opposite end of the penis to straighten the erection out, an incision with grafting where we cut out the plaque and put a patch graft in, or a penile implant. A penile implant is a procedure which I'll talk about in more detail for treatment of erectile dysfunction. It's really an ideal thing for men with Peyronie's disease that also have erectile dysfunction. So that's my segue here into talking about the options for treatment for erectile dysfunction. I would normally take questions at this point, but because we're running behind, I will go through this part and then take questions at the end. So who can treat erectile dysfunction? Like I mentioned before, primary care physicians and are really becoming much more comfortable talking about erectile function. Since the advent of Viagra, I really think primary care doctors have been more comfortable talking about this. Now there are more options and more treatments out there for men with ED. Additionally, any urologist should be comfortable talking about erectile dysfunction, talking about the initial options for treatment, but it really is a much smaller subspecialized part of the urology practice that's a prosthetic urologist. Of my group of 27 doctors, there's really just me and one more that really will do a fair number of the prosthetic surgeries. And that's because it is a nuanced procedure, and I think that there really are, you have to have a passion for wanting to do these surgeries if you're going to be doing a lot of prosthetic surgery. So what are the options? Pills, injections, suppositories, vacuum erection devices, and then the penile implant. And I'll go through each one of these in a little bit more detail. So to start with, the pills or oral medications are very common. Most men have heard about these options. Viagra, Cialis, Levitra, Stendra, and some other ones are all available. They all work in the same way with slight variations. But the way they work is they allow the blood vessels in the penis to be more sensitive to stimulation. Viagra works very quickly. Cialis is more of an extended release medication. Really important, which a lot of patients don't know to do. Viagra and Levitra, which are really common medications, are really affected by food. So it's really important to take those medications with an empty stomach in order to have full effect. They do work in many men. 60 to 80% of guys will have some response to Viagra. But men that had their prostate removed, men that are diabetics, do have a decreased response to these type of medications called PDE5 inhibitors. Side effects often are stuffy nose, flushing, muscle aches can occur. They are contraindicated. You cannot take any of these medications in this class if you take nitroglycerin for chest pain. As I mentioned, most men that come to me, the urologist's office, have at least considered and talked about these pills. So I do like to really focus a lot on the other options. for treatment of erectile dysfunction for men that have tried the pills and they haven't worked. A vacuum erection device is a cylinder that goes over the penis. It forms a vacuum or a negative pressure space. Once the vacuum is in place and blood is then pulled into the penis, and therefore the penis then becomes engorged. You place this ring on the base of the penis. This constrictive band allows you to maintain an erection for sexual activity. Satisfaction rate is really variable depending on how much a man is bothered by the ring, but it does allow for an erection to occur in over 75% of men. However, because of blocking of the ejaculation and penile discomfort, there are a big set of men that don't continue to use a vacuum erection device. Urethral suppository is a medication that needs to be refrigerated. It is prepackaged in this apparatus that allows for a small pellet to be deposited into the urethra. That pellet is then pushed into the urethra and then dissolves and is absorbed by the penis. It allows for an erection to occur in about 50% of men. The side effect is because it's absorbed by the penis, it does get absorbed by the surrounding tissues, and some men do get lightheaded or dizzy associated with it. I do recommend that the first time you try this, we do it in my office or the office of the prescribing physician, because it can make your blood pressure drop. So I like to check a man's blood pressure before and after they try the medicine. And I think it's easier to learn how to do it if you do it in the office. That said, I do have a fair number of men that don't like doing this because of A, the cost, and B, the discomfort associated with this application. Much more commonly, I teach men to do a injection into the penis. As you see here, I think you can see my pointer. There's the two tubes on top, those are erectile bodies. The needle then comes into one of those erectile bodies, and those two bodies talk to each other. When the medication is injected directly into the penis, it allows those blood vessels to dilate directly, especially for men that have nerve injury, either from diabetes or from prostate removal, that the signaling from the brain doesn't get down to the penis. We get to skip that by giving the injection directly into the penis. And those blood vessels should respond very nicely in those situations and allow for an erection. Over 60% of men were satisfied with these injections. However, with time, there is some drop in satisfaction and of the response a man gets from these injections. There is a small risk of bleeding or bruising at the area of the injection site. I think the biggest risk of these shots are that because they're so potent, there is a small risk of getting a prolonged erection that lasts for more than 4 hours, and that's an emergency. And lastly, what I'd like to focus on is a penile implant. A penile implant is a surgical procedure. What we do is we replace these two cylinders up top here. These are erectile bodies, and replace them with two cylinders that are filled with saline or salt water. Those cylinders are then controlled by a pump that sits inside the scrotum and a reservoir that sits up in the lower abdomen that holds that fluid when you don't want an erection. When a man wants an erection, they squeeze the pump and they can shift fluid into those cylinders. And when you want the erection to go down, you press a release button, the erection then dissipates. A very highly satisfactory surgery. Men are really happy that they have it, and there's many men that have satisfied partners. We'll talk about that a little bit more. Like any procedure, there's risk, including infection, injury to other structures, needing to replace or exchange the device because of malfunction. The average device lasts somewhere around 10 to 15 years. And when the device malfunctions, if a man wants to continue to be sexually active, we need to have another surgery performed. There are different types and variations of penile implants depending on what's best for a patient. There's a malleable device, so two cylinders or rods that are placed that are always firm, that can be bent up and bent down. A two-piece device that allows the cylinders to be controlled by a pump without any reservoir in the belly. The upside of this, it's a simpler device. The downside, there's no reservoir, therefore, even at rest, a man does have about a 60 to 70% filling or fullness of the penis. Or the most common implant that we place is an AMS 700 device, which has the two cylinders, a pump in the scrotum, and this reservoir of fluid that can hold almost all the fluid that's in the penis at rest. Therefore, a man really does mimic their previous normal erectile function with complete flaccidity and then very good erection and firmness when it's fully inflated. Also, the AMS 700 device is the only implant on the market that comes coated in antibiotics. Like I mentioned, the biggest fear and concern with a penile implant is infection, and therefore, because this device is coated with antibiotics that are slowly released once it's implanted, it does reduce that risk of having an infection significantly down to about 1%. So how does this work? Try my best to demonstrate with words, but they say a picture is worth 1,000. So if you look here, there's the 2 cylinders that are inside the penis, the pump that's in the scrotum. When you squeeze, you're shifting the fluid from the reservoir, filling those 2 cylinders, giving a full erection. You can then leave that erection as long as you like. When you press the release button, then the fluid then leaves those cylinders and goes back into the reservoir until you go to inflate it again. And showing a real patient, which I think it's nice to see. You can see the device is completely concealed, 100% inside this patient's body. You can see he can pull the pump up to the skin and now is inflating it. As he's inflating, he's shifting that fluid from the reservoir up here into the 2 cylinders. Sometimes it may take 30 or more pumps in order to really get the device to fully inflated. Once it's fully inflated, a man should get a full erection. And you see everything really is completely concealed inside the body. And once a man wants the erection to go away, you press this button. You can see he pulls up to the skin right there on the bottom and pushes the button. Then the fluid then exits from the penis and goes into the reservoir until its next use. And sometimes to completely get every drop of fluid out, if you want to have a complete emptying or a flaccidity, you can squeeze the penis in order to get all the fluid out. Over 90% of men are satisfied when they have a penile implant placed. Additionally, those men's sexual partners are also well over 90% satisfied with these devices. As I mentioned, surgery does have risk, especially when we're planting a device inside a patient's body. There's a risk of mechanical failure. Like I said, the average device lasts around 10 years or more, but I have seen these fail early, in a year or 2 after placement. I have seen them last over 30 years. But if they do have a mechanical malfunction, they do need to be replaced. Some men have pain with the device. There is the pain associated with the healing process, which usually dissipates within 3 to 4 weeks after the procedure. And a man has to wait 6 weeks in order to have sexual activity after an implant's placed. There is a risk of infection, and like I mentioned, we do everything in our power to reduce the risk of infection using coated implants, as well as giving antibiotics before, during, and after the operation. It's designed to be a permanent solution. It's spontaneous. You can keep an erection as long as you want. It's been around for over 40 years, and so we do have lots of experience with placement and the potential pros and cons of a penile implant. Insurance often does cover a penile implant, and before it's placed, we will investigate with your insurance provider to ensure that you have coverage and you would know what your copay would be. In summary, I know I'm focusing on an implant now at the end, but there's lots of options for all men with erectile dysfunction, as little as lifestyle changes in the way you take oral medicines, to injections or vacuum devices, testosterone therapy, lots of ways that to help a man with erectile function, and really trying to figure out what the best option for that patient and their partner is. So I think the first step is talking to your doctor. I'm very happy to see anyone that's interested in talking about erectile function on a one-on-one basis. I'm really lucky here to have Cliff Pollock to talk about his experience with erectile function. So I'm going to open up the floor to Cliff. Mike, is that right?
Yep, there he is.
Okay, and then we'll answer questions at the end.
Perfect. Yep.
Okay.
Well, good evening. Excuse me. Good evening, everyone. What you're going to hear basically is journey that I took from the time I was diagnosed with prostate cancer through the implant surgery. When I was 58, I was diagnosed with prostate cancer and decided to have my prostate removed. My regular doctor gave me Viagra because I had no erections. And the Viagra, all it did basically was give me lots and lots of headaches. And it just didn't work very well, even though I took it without food and followed the directions. So after the Viagra, they put me on Cialis and Levitra, and the same exact thing. The headaches were so bad, I could not pick my head up off the pillows. So after that, I went back to him and he said, there's this external erection device, the vacuum device, and I bought one. And I will tell you, you want to buy one from a store that is a medical store. You don't want to go to some of these, sex stores to buy them for $25. Those are not the good ones. Anyway, it did work. It's not spontaneous. Unfortunately, one of the problems is when you use the erection device and you put on the ring, which I call a tourniquet, your penis becomes cold, it becomes blue, and it's not very appealing to your partner. Also, taking the tourniquet off of the penis is hurtful. So after about 4 months, that went bye-bye, and I was left with basically nothing. My doctor at that point, my internist said, I don't know what to tell you. And for 2 years, basically after that, I went into a major depression because I could not get an erection. I felt like I lost my manhood. I could not please my wife the way a man is supposed to be able to please their wife, and got really, really depressed. Luckily, I got an invitation to a seminar like this, except at that point it was live. I went to the seminar with my wife, and we heard about the different treatment processes that were available. And after looking at them and not wanting to deal with the mousse, those little pellets, and definitely not wanting to deal with the injections, we turned to the inflatable penile prosthesis. So we went home, talked about it, went back to the doctor, and had a long discussion with him. I found out I was a candidate for it. And the day after my 60th birthday, I did the second best thing I ever did in my life, which was to get the implant done. I am now 75 years old. My first implant lasted 14 years. It never, ever failed to give me a solid, rigid erection, good for any type of intercourse myself and my wife desired. After 14 years, it did fail, and I went back to the doctor, and I had a new one put in. The new one that I had put in was a little more advanced, different model, but it works fantastically. If this one lasts 14 years and I'm still around, my doc will see me again for another one. It's as simple as that. But truthfully, the implant works wonderfully. You don't have to worry about things such as going on vacation and refrigerating the medication. And you don't have to worry about going through the airport and carrying a external vacuum device. Everything is in you. People ask me, well, when you go through the airport, do the alarms go off when you go through the metal detector? The answer is no. And they ask me, what about when they scan you with that stupid wand and the wand comes up the inside of your crotch and nothing happens? So you're basically free. It's with you all the time. You want to use it, you use it. You don't want to use it, you don't use it. Also, people ask me, What does it do for, does it stop you from getting MRIs, CT scans, any PET scans, anything like that? The answer is no. Does it interfere with urination or anything with the bladder? The answer is no. Basically, it is there for you to have sexual pleasure with your partner. And I will tell you that my wife has said more than once, if she did not know that I had the implant, she would not know that there was an implant in me. It looks and feels that natural to her. And as far as I'm concerned, the orgasm that I get, even though I do not ejaculate, is just as powerful as the orgasms I had when I did ejaculate. So it's a wonderful device, and I suggest that if you decide to do it, take your spouse with you to the doctor. ED is not just a male issue; it's a couples issue, and it's nice to have both people on board when you go speaking to the doctor because they have lots of questions. So I'll turn it right back now, Mike. This answer question.